So today it's not the inspiring part of the talk. We are going to talk about something which is interesting, however, since we are talking out of the box. Manisha, that was a very well covered topic, and I think that's a thought you have sowed in everyone's head, that not every young diabetes is type 1 and every age can also be type 1. So the whole spectrum. Now I'm going to talk about non-insulin drug use in type 1. Now this is again out of the box. I think the topics have been selected very well because we have to think beyond what we are doing as a typical in our practice. So very simply, I'm just going to say that, does insulin always meet all our needs? And there are challenges. So challenges are variability in blood sugars, there are hypoglycemia, weight gain, comorbidities that exist. Plus we want to target insulin resistance, obesity. Today we have so much talk about cardiovascular risk reduction and renal risk reduction in type 2, then why not in type 1, where we know that these risks exist, maybe even more. So if you look at the pathophysiological rationale, why are we talking about non-insulin? Because it's not just insulin deficiency. In fact, a lot of insulin resistance, as was shown by Manisha in her last cases, right? Insulin resistance, in fact, PCOS, PCOD is very common in type 1 as they grow older. Double diabetes is seen very much. So glucagon dysregulation does exist with type 1 as well. Incretin impairment does, and renal glucose reabsorption, the way we are talking about in type 2 diabetes where SGLT2 works, that also is a pathway in type 1 as well. So when we are talking about these drugs, one thing which I have to emphasize is these are adjuncts. These are not substitutes to insulin. It's always adjuncts which complements, does not substitute. With that thought in mind, because I don't want anyone to go back with the thought that these are great drugs, which are, but as an adjunct. So first and foremost, the oldest and the most wonderful metformin. Very simple for this audience. Anyone who's here understands this because it increases insulin sensitivity, it decreases the hepatic glucose output, especially nighttime when you get the dawn phenomena, the fastings are high. Again, the HbA1c benefit per se is modest, but all the studies are Western because we have more insulin resistance, could be better in Indian context. But it's very useful in PCOD, insulin resistance coexisting, especially if you see after adolescent girls with type 1 diabetes gain weight, and by the time they're 18, 19 plus and overweight, even without PCOD, we find it like a double diabetes kind of presentation, and they do respond very well on addition of metformin. So the limitations could be GI side effects and maybe limited effect in lean patients. So I have at least 100 young people that I have used metformin along with insulin therapy, and usually this is the age group where I have used it, and it has helped. And later on, once they have stabilized, especially this transition age from 17 to 22, 23, when they are less active, overweight, that is a time they have needed it. And of course, some with PCOD who are continuing to use it. Rest we have stopped later. So it does work. I think it's worth considering. Yes, GI effects are there, but Indians do tolerate it pretty well. So think about it in your older patients. SGLT2, now this is off-label, not FDA approved. It is restricted approval in Europe. But if you think about it, we have them available. They work via the renal reabsorption is being reduced. It's a great way to bring down blood sugar levels. So adults who are overweight and uncontrolled. So it does work, and again I have used it in a lot of this is off-label use, but one has to be very, very careful. UTI, GTI, as in always, but in addition, euglycemic decay. That is something because osmosis, the diuresis that is happening, electrolytes which are going down, again because of all this, and if they go into dehydration, if they're not well hydrated enough, all those aspects have to be very well trained. But with good training, with good education, if a person with type 1 diabetes is empowered with education of looking forward, it works very well. Especially if you have people who are needing a very high dose. Because see, it's a cycle. You're needing more than your body weight of insulin Suppose a person is 60 kg and is needing 80, 90 units of insulin. You're adding maybe metformin and SGLT2. So the requirement is coming down, weight is coming down, insulin sensitivity increases the moment the insulin requirement comes down. Again, that leads to even better utilization. Person exercises more. So it's a very positive cycle. I have quite a lot of young girls and boys that we have given this and found very good results. And of course, it needs very good education and warning. And again, it's off-label. That is something we have to understand. Voglibos. Now, I've just chosen drugs which we use in our day-to-day practice rather than those, molecules available all over the world and not available here. So Voglibos, normally it's not very well recommended or accepted internationally because they do not have that kind of carb diet. But specifically talking in low resource setting. For example, I have children who are laborers, kids who have literally nothing but chutney roti to eat. Right? No matter how much we teach them about proteins, even a simple matki is not affordable at times. So end up eating with only bhakri, chutney, bhakri, thecha is all they eat. If that is a diet and with that kind of carb content in their diet, even a carbos, because postprandial peaks and the requirement becomes very high. Because to fill up their tummy, they're eating like 4-5 chapati khali. And that's all they have because they don't have the protein for satiety. They don't have fiber to make their food, process slowly. All those things don't exist, especially in those situations and also in others. So like type 2s use it like a party pill or a cheating pill. So something like that for type 1s also. Why not give them? There's nothing wrong as such, the pathway. It is not harmful in any way. Of course, we know it causes bloating, flatulence. Some can have diarrhea, but we have used it and it has worked very well with those people who don't have a choice but to have a carbohydrate meal only. So think about it, it could actually help. And we have seen that it has brought down the postprandial peaks significantly in these. As a result, reducing the insulin need. And it's not as if we want to reduce insulin need to save insulin. It is because the more insulin they're using, it's also weight gain, it is also more insulin resistance, it's also all the other aspects that come along with it. So it helps. Now this is can't call it new, but this is something we have more data on and very, very promising. And again, this is expensive. One day when all these go off patent and become available, then probably this will become a very important aspect of type 1 care as well. So we know that because it suppresses the glucagon secretion, there is a reduction in the postprandial hyperglycemia, slowing the gastric emptying, again blunts the glucose spike. Again, it has satiety, reduces appetite, weight loss, improves the insulin sensitivity, lowers the insulin requirements significantly. See the 15% reduction. And variability and time in range has improved with use of GLP-1s. Of course, we all know the GI side effects, which are always there with GLP-1. That has to be considered. Hypoglycemia risk would be there because there's a reduction in requirement, so insulin has to be reduced, which is understood that if you are living with type 1 diabetes, you're anyway monitoring and anyway you're adjusting your dose as per your blood sugar levels. Now the interesting part is that now we have the dual agonist. So is there a difference? Because GLP-1 versus GLP-1 and GIP. So with tirzepatide on the block, so this acts with the dual mechanism, and here, because there's greater weight loss, again, it also works other than the sensitivity due to weight loss is also the adipose metabolism effects. That is also helping. So in your overweight adult type 1s, so criteria would be adult, would be overweight, of course, because the main thing is working at the adiposity level, then a better CGM control. There are a lot of pilot T1D studies which have shown very good outcomes. In fact, a lot of people are using off-label, they're microdosing, they are tweaking it across the world. Especially type 1s are known for their own creativity and innovation and taking their treatment into their own hands, justified so, because you can't always wait for some things, but it is otherwise safe. So of course the limitations are, of course one more advantage is the CV and renal benefit. So think of a patient with type 1 diabetes and has CV or renal problems, and if we could, that person is obese or needs a very high insulin requirement, and could be given GLP-1 or a dual agonist, which has shown better results, more weight loss. Of course, there would be a risk of hypoglycemia, which, as I said, needs monitoring in any case, and we still need studies. Everything is off-label, but a lot of potential. I see this happening as a, not an adjunct, but probably a regular treatment once the studies are out, right? So I'm just comparing both of two. This we don't have, so I'm not going to talk about it. It's approved in USA. It works on the postprandial glucose, but we don't have it available here. So that was the drugs we have. The other agents we have is pioglitazone, again, weight gain, edema, so not really recommended. DPP-4s don't really work, hardly any, because you need some insulin reserve for them to work. And so where would you like to use these drugs? So in a clinical application, always, of course, remember it's adjunct, never insulin substitute. So metformin, if you have insulin resistance, PCOD, overweight, you can think we're talking about adult patients, even adolescents in this case. SGLT2, adults with obesity, CV renal risk, and very good education. That is something we have to keep in mind. GLP-1 RAs, especially the dual, choose with people who have obesity and need very high doses of insulin, who have CV concerns. These are people who would benefit with GLP-1 or the dual agonist. Pramlintide we do not have, but it's for postprandial control. Voglipose, people in high-carb diets and who would need higher doses of insulin to control that, somewhere this could work. So this is how we can look at it. Future directions would be a combination of GLP-1 and SGLT2 for obese type 1, because more and more, we used to have those lean type 1s, that BMI, that has changed totally, even the rural spectrum, where I see now the older ones especially, their BMIs are getting bigger and bigger now. Of course, immunotherapy and adjuncts would be another thing, phenotype-driven therapy, because as we saw in Manisha's presentation also, different spectrum of phenotypes. So personalized medicine would be one thing, and of course, cure would be the best, as we are already hopeful with the latest non-immunosuppressive requirement of that has been so wonderful. If that happens, islet cells without immune suppression, which has the one case which has been successful, we are looking forward to that happening. So to conclude, think of adjunct drugs, even if they are off-label, for the betterment, being safe in the selected cases. Let it be a shared decision-making, and it has to be with a lot of education. Right. Thank you.
Thank you so much, ma'am.